Hello and welcome to the Neurocritical Care Society podcast. This is our Perspective series. I am your host, Dr. Nicholas Morris from the University of Maryland Shock Trauma Hospital. Before we begin, please note that the views and opinions expressed in this podcast are solely those of the hosts and guests and do not necessarily reflect the official opinions or positions of the Neurocritical Care Society. I am really excited about our guest today. We have the privilege of hosting Professor Werner Hacke, who is professor and chairman at the Department of Neurology at the University of Heidelberg for many years and is now a senior professor of neurology. He had a leading role in the development of neurological critical care, including the implementation of acute stroke management and hyperacute stroke unit care. He was really one of the leaders in many of the trials looking at thrombolytics and had pioneered decompressive surgery for malignant cerebral edema. He's among the most highly cited researchers in all of vascular neurology. He was a founding president of the European Stroke Organization and has served as president of the World Stroke Organization. He's an honorary member of the Neurocritical Care Society, a distinction that demarks leaders within the neurocritical care field across the globe. Dr. Hacke, thank you so much for joining us on the podcast.
It's my pleasure. Thank you for having me.
So, many of our listeners may know you as this towering figure in stroke neurology and in neurocritical care, but I'd love to sort of start at the beginning. What first drew you to the field, and how did you specifically get involved in neurocritical care?
Yeah, it's a very long and windy road. When I finished our college, my grades were not good enough for medical school. So I started studying psychology. And after a year in psychology, I was admitted to medical school at the University of Aachen. And I also were allowed to continue studying psychology. So I did it both in parallel. And so that looked like physician and psychologist, my route would go into psychiatry. And I started off in psychiatry for 3 years. Interestingly, during that time, I built up the first psychiatric intensive care unit in Germany, because we had, at this very early time point, that was the mid-70s, we had a lot of drug people from Holland coming over. And so psychiatry had to take care of toxicological emergencies. So that is when I had my first contact. And to become a full psychiatrist, I had to do neurology for also 2 years. So I went to the University of Aachen, where a very famous neurologist, Professor Klaus Pöck, was the head, and he was a leading figure, world leading figure in neuropsychology. And he thought, here is a psychologist coming with a background in psychiatry, maybe I can get interested in neuropsychology. Well, I got interested, but I got interested in neurocritical care, because at that time, in 1973, Aachen had already a neurological critical care unit. 6 beds, 3 ventilator beds, and all run by neurologists. So no anesthesiology involved, nothing. And at the same time, we also were the neuroradiologist for the service. And my close friend and one of my biggest idols, Professor Hermann Säumer, was there. He is 4 years older than I am, and he was already a neurologist and a neuroradiologist. And that is what paved my career. So a long answer, but it was really an unforeseen route.
Oh, that's fascinating. The idea of psychiatry critical care is totally foreign, literally, to us Americans here. So seeing how that sort of pathway developed is really unusual for us to hear about.
Yeah. It had to do with the fact that the psychiatric hospitals were always alone-standing hospitals. They were not included into a bigger hospital with all the other specialties. And the next specialty hospital with anesthesiology was 20 miles away. So we had to be self-helping.
Understood. Now, so you mentioned you sort of stepped into a neurocritical care unit that was already run by neurologists back in the early 70s. That also was different from the United States in the way neurocritical care developed here. What were the things that were in place in Germany at the time that allowed neurologists to run a neuro ICU, and maybe how has that developed over time?
Well, there was no formal training for that. It was just like the heads of departments decided that we had to take care of critically ill patients that were not allowed to go into other intensive care units. That was a time when a stroke patient would not be admitted to an internal or an anesthesiological critical care ward. Simply, they would not take them. And instead of letting them die, we took care ourselves. And at that time, we already had 15 critical care units run by neurologists, some run together with neurosurgery in Germany.
That's very, very interesting. So what was keeping them from admitting these patients to their unit? Was it sort of nihilism around prognosis, or was it other things?
The fear of being flooded with neurological cases.
Mm.
Like nowadays, there is always a shortage of beds, right? And the anesthesiologist did not want to have his bed occupied by neurological patients that were more or less unplanned. They like much more the elective things, so like admit, 3 days, discharge. And that is, as we all know, not the routine in neurological cases.
No, definitely not. So you said that at that point there was really no training for the neurologist going into this field. So I imagine a lot of learning was on the job in ventilator management and hemodynamics, et cetera.
Yeah. Well, of course, we were sent to anesthesiological wards and learned techniques there. Like even nowadays, most of the residents that do their shifts on the neurocritical care, they have a 2 or 3 week training period in anesthesiology for intubation, central lines, all the things that can be learned, of course. I mean, this is not a magical thing. I always said what anesthesiologists can learn, neurologists can learn too. But what
Absolutely.
neurologists know, many anesthesiologists don't know about the brain.
And how has this changed over time? What kind of formal training is now in place for those that want to do neurocritical care in Germany?
Yeah, well, neurocritical care is a subspecialty. You can get into neurocritical care as a neurologist and as a neurosurgeon. It requires 2 years additional training in addition to your residency of 5 or 6 years. So we don't have fellowships, right? So a resident in Germany has 5 years residency. During that time, he rotates into the stroke unit, must rotate into critical care, must do ultrasound, must do electrophysiology. So that is 5 years. And then in addition, you do a 2-year very comprehensive training. And it's a board certification that is available for neurologists and neurosurgeons.
Right now in the United States, there's a little bit of anxiety around maybe not enough neurology trainees choosing neurocritical care. So the numbers kind of went up for quite a while, and they seem to have plateaued for the last 5 or 6 years, while the number of training spots has actually increased dramatically. And so more and more training spots are going unfilled. What is the enthusiasm for training in neurocritical care now in Germany?
Well, the enthusiasm is there because it's required if you want to get promoted into a leadership position. then you have to have this additional training. And it's, I mean, we also have shortages of motivated personnel right now. Luckily, neurology is one of the disciplines that has still the highest demand by young physicians to get into this specialty. Others have even more problems. And so not every position is filled anytime, but most of the times people have their contract as at a hospital for 5 years to reach the board certification. And then it can be prolonged by 2 more years for the sub-certification. So they stay in the system. So they don't have to apply elsewhere or make a decision now to go into it. It comes kind of naturally. And I should mention that this board certification is around now for 30 years. For 30 years, we have this subspecialty neurocritical care.
Yeah, so a lot more history than we have here in the United States, where our official board certification just started really a few years ago.
Yeah, I know.
Yeah, yeah.
But it's also unique in Germany and in Austria. The other European countries don't have it, and there are politics behind it. There are many countries in the European Union where they have a specialty of critical care medicine. And that is only accessible to internists and to anesthesiologists. And they don't like the idea that neurologists and neurosurgeons do their own stuff.
Right. Yeah, this is these debates are ongoing here as well, and there's been talk. There's a white paper that came out from the Society of Critical Care Medicine, sort of looking at some of these European models and maybe trying to imitate them in the United States, where we would perhaps have a general critical care training with multiple entry points from internal medicine, neurology, surgery, anesthesiology, and everyone would have the same training for a year, and then the next year go and do your subspecialty training. Because right now it's completely different pathways depending on where you're coming from, and it's a little bit confusing. Yeah. I'd like to sort of flip the page now and maybe talk a little bit more about your sort of personal experience in the ICU. I'm wondering, over the years, what are some of the big advances that you've seen that have really changed the field? Now, you've been part of many of these through your research in stroke neurology, but what have been the big changes in neurocritical care that you kind of experienced during your career?
Well, the first big change was, of course, the advent of intra-arterial treatment for stroke. And that started in 1981, and that was the cornerstone for even further development of neurocritical care. The second development was that, unlike 10 years before, now all beds on a critical care unit, neurological critical care unit, are ventilator beds. That is also extremely important. The third thing was that we really started to increase the neurological monitoring, which in a very early time point was only EEG, right? And to convince our friends in neurosurgery to put epidural catheters or to do intraventricular lines in patients that were not their own patients, right, was difficult in the beginning, but it turned out to be extremely helpful. And with the advent of decompressive surgery, of course, that was another step forward in the very close collaboration. And the neurosurgeons learned that sometimes the indication is made by neurologists. And we call them to do what we would like them to do. That was a complete change of attitude. But it worked. It worked, and the neurosurgeons in the end, at least most of them, were quite happy with the collaboration because it gave them also access to high-level publications. which neurosurgeons do not that frequently have the opportunity to. And so it was a win-win situation. And I think this going together between neurology, neuroradiology, and neurosurgery, kind of the brain disciplines. In most German university hospitals, the combination of neurology, neurosurgery, and neuroradiology is the third largest force. Follow only surgery with all subdisciplines and internal medicine with all subdisciplines have more patients and have more revenues than the neuro cases.
Very interesting. Now, of course, you didn't just observe these changes happening, you really led them. And so when you talk about decompressive craniectomy, I mean, Destiny 1 and Destiny 2, this is your work. Maybe you can talk a little bit more about how you developed this collaboration with our neurosurgical colleagues, not just in clinical work, but in building these massive trials that change care.
Yeah. Yeah, well, we had been entertaining decompressive surgery for several years before we started the major trials. And there were already meta-analysis of all our cases, and we already could show that the earlier you do it, the better the outcome is. But wherever we went, also in the United States, but mostly in the UK, they told us that this is an unethical approach and this should not be promoted, and there is a need for a randomized controlled trial. Nota bene, a randomized controlled trial that decides between live or let die. This is not an aspirin controlled trial. This is, if you do it, then the chances of survival and also of relatively good survival for such a deadly condition, is fine, is around 20% mortality left versus 80%. That is an ethical dilemma. And after we have done those trials and we saw that the results of the trials and the meta-analysis are exactly the same like the results of the retrospective analysis that were published 10 years before, made me think about, is a randomized controlled trial for deadly conditions the right way to go? And I also carried with me for a long time the idea of doing a randomized controlled trial for basilar artery occlusion. But I didn't do it because I did not want to have the same experience one more time. I know the results and I decide by randomization who lives and who dies. No, that is a difficult thing to do. And it tells you a little bit what we have to think about is how do we really promote critical care research in deadly cases. I'm not talking about randomizing to one or another form of antihypertensive treatment. That's not what I'm talking about. But those live and let die decisions, they are not adequately answered by randomized controlled trials. And the reason for Destiny 2, you may remember that in Destiny 2 we had a very special analysis plan. So once we crossed the significance level, the trial was stopped, right? Because I didn't want to randomize more than needed. And nowadays I would ask myself, would I ever do it again?
Yeah. If you don't mind, maybe we can talk a little bit more about Destiny 1, Destiny 2, because I think we still have ongoing disagreements maybe about the interpretation of these studies at different institutions with our neurosurgical colleagues.
Yeah.
One thing that really bothers me sometimes is this sort of strict interpretation of the age cutoffs. So in Destiny 2, you showed a mortality benefit, but really not an improvement in functional outcomes. And some surgeons have used that to say, we're not going to offer surgery for, patients that are 61 years old, for instance. What is your interpretation of the trials and this age cutoff, and how did you use it in your clinical practice?
To be quite honest, the older I get, the more I understand why the result of a randomized clinical trial does not answer everything. I'm now 77 years old. 10 years ago, I would have said, if I have a malignant brain infarct, I'm 67, do it. Now I would say I'm 77. My chances of a rehabilitation success, if I survive, are not that good. And do I want to spend my life as a modified ranking of 5+? I wouldn't say so. And so that is how your own perspective changes this interpretation. Meaning, there is no 60-year cutoff. And there are surely people who are under 60, but in such a bad condition that you will not do it. Keith Richards and said, this guy, look how he looks, but he's 75 and still on the stage, right? That's different, And so individual, personalized decision-making, that's everything. And you don't do it by yourself. You have hopefully a family that is responsive to this problem, or a family that has spoken about things like that. In how many families do you believe they have spoken about something like that? Even in physician families,
Very few.
avoid it.
Yeah.
Right?
Yeah. I think one of the other interesting conversations I've had in the interpretation of these studies is these studies were not done in the United States. And it's my understanding that the rehabilitation system in Germany is quite excellent. And in the United States, it's really variable. It depends sort of on the family's resources and what's available locally. What role do you think the post-hospital rehabilitation has in the decision for surgery?
Beyond surgery, also for mechanical thrombectomy. What you gain in the first couple of days in the hospital can be easily lost in the next weeks without a proper rehabilitation. Not everyone is a stand up in neuroradiology and has no symptoms at all. They all need, if we look at the modified ranking distributions of the big meta-analysis, more than half are not completely independent. And you can lose everything that you gain with a successful recanalization or a survival despite of a malignant brain edema by not offering adequate follow-up treatment.
Right. Now, you mentioned the modified Rankin several times, and I think I'd be remiss not to ask you about this as an outcome. We've seen it as a dichotomized outcome in a lot of our studies. Where we dichotomize changes, is it 0 to 2, 0 to 3, or even in some recent studies, 0 to 4 is considered a good outcome in these really severe brain injured patients? Or should we really be focusing on ordinal analyses and shift? What's your view of the Rankin as an outcome after, let's say, in stroke trials, and how should we best use it for patients with severe brain injury?
Yeah, I'm quite happy with the modified ranking scale as an outcome measure. It's simple. It's, of course, not linear, but it is the best reflection that we have right now and the easiest to handle. I'm a strong proponent of different dichotomies for different conditions. If you do say a thrombolysis IV tenecteplase trial in mild strokes, you must have a 0 or a 0 and 1. If you do it in malignant brain edema in 65-year-olds, I think it's a success if they get out there with a 3, you know? And this is also why I always was extremely critical about not allowing patients with a pre-existing modified ranking of 2 in a trial where the success would be in 1. Yeah. And and in most of the analysis that we look at nowadays, the trend goes in the same direction, whatever you do. Wherever you dichotomize and or if you do an ordinal analysis. I've never seen anything where the dichotomy showed a very strong signal and the sliding scale did not, or the ordinal analysis did not show the trend, at least. Never an opposite result.
Yeah, no, I think that's right. I'm thinking of some of the ICH trials where maybe there may be some trend in the ordinal analysis, but no significant finding in dichotomized analyses. I think Misty might have met that criteria.
Yeah.
But that's a good point. They rarely go the opposite directions, right? That's almost a never occurrence. Yeah, great. I think we've talked enough about decompressive crani, but I could talk to you about that all day. I'm wondering, 'cause I do talk about this all day on rounds and with my surgical colleagues, and I can't thank you enough for all the work you've done in helping us. I can see how ethically challenging doing this work is, but it's really based on your work that we're able to have more informed conversations and able to move things forward, I think. You mentioned this issue of sort of the ethical quandary of doing randomized controlled trials. If not randomized controlled trials, what kind of studies would you have in mind for these patients that really where the intervention could be life-saving?
Yeah. Prospective analysis of cases in selected centers which have a high level of standard care. That is for me the best thing to get this knowledge. And again, if this is not something about death or life, if it is about cost or anything else, randomized controlled trial. But if you run the risk, like in decompressive surgery, with a 20 versus 70 or 80% mortality, that goes beyond what I would feel adequate nowadays with my knowledge from the past. And, especially since the early trials or the early observations simply mirror the results of the randomized trials. The same is true with the Chinese basilar trials that simply copy what we published in 88 with the basilars.
Yeah. I think you made a really good point, though, about the need to do these in centers with a high level of standard of care. And I think it's difficult to interpret some of these comparative effectiveness trials or implementation bundles when they're done in institutions or in countries where perhaps they don't have the same standard of care that we might look at as the optimal standard of care.
Yeah.
I guess how should we ensure, if we're looking at that type of data, that data is being generated by places that have a high standard of care?
Yeah.
Who's to say?
Honestly, the bundle studies that were published recently, again from China, I think it's a very good step forward. A good step forward to establish a standard of care through many sites, simply by following a clinical research plan. That is a positive thing about it. And, we have think of one shortcoming in all our trials that we did with brain hemorrhage, the Novo 7 trials. Okay, the Novo 7 trials suffered from poor standard care. if you look at the Novo 7 trials, how few patients with intraventricular extension had a ventricular drain. I mean, how can a hemostatic agent help if you don't do the physiological basics, right? And
Right.
these trials would probably have been much, much better when standard of care was there. And in your question list, you had pragmatic trials.
Yeah.
I hate pragmatic trials because I believe pragmatic does not stand for real life. Well, it stands for real life, but for low quality real life.
Mm.
This is one of the reasons why hypothermia never made it, because it was impossible to bring centers to the level to give moderate hypothermia to 32, 33 degrees to patients. They said, we cannot do that. It's not working here. So let's do 36 degrees, right? And that is what happened. And that was pragmatic. Oh, it was so pragmatic because it reflected the insufficiency of the health system in some of the centers.
Yeah. I think Fabio Taccone has published on looking at what he calls high quality targeted temperature management and how infrequently that's achieved.
Yeah, it's difficult. I mean, this is a 32-degree 2-day or 3-day hypothermia in a neurological critical ill patients is about the maximum that we can do on our critical care units. With all the things around it, the coagulation and respiratory problems and so on and so forth, just to achieve this, over days, what you need.
Yeah, we were one of the I think highest enrolling sites in the Intrepid study, where we tried sort of preventative targeted temperature management in patients with severe stroke, and just keeping people at 37 was an incredible challenge, dealing with shivering and sedation.
Yeah, absolutely. Yes.
It was really hard.
Yeah.
Yeah.
I mean, you end up with a shivering thing. You end up of having them with muscle relaxants, which causes other problems. So, I mean, this is not an easy thing to do. But, in other disciplines, they do the not easy things.
Yep.
Yeah. Okay.
Can you give an example of that?
Oh, well, think of stem cell transplantation. But it's not easy, right? It's not easy, but it is standard of care in many, many maximum care hospitals. And we cannot say that a moderate hypothermia of 32, 33 degrees for several days is standard of care in many high care facilities.
Right. All right. Well, I'd like to sort of shift gears a little bit and talk a little bit about some of your personal experiences. I'm wondering, was there a case or a series of cases that really inspired you to take a lead from on the research side, in stroke neurology? And it sounds like you came at this almost, from a psychiatrist or psychologist point of view, and then you ended up, we're talking about surgical decompression and thrombectomy and thrombolytics. I imagine there's some story there, something that got you inspired to really follow that line of investigation.
Yeah, the main thing was I couldn't stand to see patients in front of me where I know if we cannot do anything, they will die. And these were not all the very old ones. When you think of when we started with the basilar artery occlusions, these were young people with dissections and emboli. And the first one that we did in Aachen at that time was the third in a row within 3 months. All young, all following sports with a dissection. We didn't know that it was a dissection at that time. It would be quite clear. Nowadays, every resident would say, "There's a dissection." Now, we had no idea. We did the angiogram, and there was an occlusion, right? And they died in our hands. And then with the third one, Hermann Säumer and I went to our department chair and said, "There's another one. Can we?" He was the ethical committee for us, you know.
Ah.
There was no ethical committee that allowed us to do this case. And so we did it. Hermann did the intra-arterial thing. I did the kind of anesthesia because anesthesiologists did not want to do it. I was the attending on the critical care unit at that time, and so I took care of that. And I also did angiograms myself at that time.
Oh, wow.
Yeah, these were the early days. And no, it was just acts of last help for someone who otherwise would die. This was the way we came from. And the interesting thing is about both the thrombolysis and the intraarterial treatment and the decompressive surgery, the animal studies came afterwards. So that was not really triggered by animal research.
Yeah, I don't think I realized that. That's fascinating.
Yeah.
Yeah, I'm wondering what was it like to round with you? If I asked one of your trainees what were rounds like with Dr. Hacke, what would they tell me?
Yeah. You must know, when I was the chair of the department, I did critical care rounds every morning. And in our system, the round is done by the head of the service, the attending, the residents on shift, plus the nurses. We never did rounds without nurses. And we never did it without physiotherapists, by the way. So it was a team that came in. And I would say most people, when you would ask them, they would say the rounds were very open. Decisions were not made without asking everybody about their opinion. And when it was, which is not rare, when end-of-life decisions, when I said, I think we reached the end, then I turned around and talked to the nurse responsible for that patient. What is your opinion? And if she would say, can we give him 1 or 2 more days? I said, fine, absolutely. I want those decisions be taken by all involved. And I believe that was the strongest psychological feature of the rounds. And to be quite honest, most of the times when I did the visits, most decisions were already made. What is the next MRI? When does he go to angio, and so on and so forth? What was left to me were those decisions, where they said, we need your decision. How much should we continue? Shall we continue dialysis? Shall we? And you know those problems. And
Yeah, absolutely.
this is what you ask.
These are the hard questions come to you. But I love the idea of building consensus within the team, and being open to everyone's opinion. All right, we've talked a lot about your work in ischemic stroke, and I think this has been the big success of our field with thrombolytics, then thrombectomy, and the benefit of decompressive craniectomy. Some of our other disease states, we haven't seen such progress, particularly in hemorrhagic stroke. I'm wondering, after witnessing these large advances in ischemic stroke, how do you think we find a way forward in hemorrhagic stroke?
Hemorrhagic stroke is not a rare disease. And I always wonder why it was never possible to set up really large-scale trials with simple questions. And yes, they were done, and then there were the meta-analysis, and then they looked like there's a subgroup that will benefit, and then you build up your next trial on this subgroup, and this trial failed too.
Yeah, I
It
think you're
is,
referring to the Swiss trial in decompressive cranie for, ICH that's within a centimeter of the cortex, and we
yeah,
didn't see any benefit there, right?
yeah. And I have no idea how to improve that, because for some obscure reasons, the brain hemorrhages still belong in the majority to the neurosurgeons.
Mm-hmm,
And
mm-hmm.
the impetus must come from them
Mm.
to do it. And yeah, I don't think that we make a lot of progress here. And yeah, that's it.
Okay. Well, hopefully seems like they are interested now in really trying to improve these minimally invasive techniques, and maybe we'll
Yeah.
see some breakthrough there. It seems like with lobar hemorrhages, there seems to be some benefit, but we're still looking for something that will improve
And
care
I
for our.
still believe it for me, it is so obvious that a properly large enough trial on treatment of ventricular hemorrhages,
Mm,
that is a no-brainer. It must be successful, right? And we still don't have it with this kind of level of evidence that we would need to be really convinced. Yeah.
yeah, I agree. We had Dan Hanley on this
Yeah.
podcast
Oh yeah.
a couple of months ago, and I think there's another clear study coming our way at some point if they get funding. So
Yeah.
we'll see if we have another study of intraventricular hemorrhage. Yes.
I hope
Um,
so, yeah.
yeah, me too. Well, this has been really wonderful. Sort of as we wrap up, we have a couple of quick questions we like to ask guests on the podcast.
Yeah.
What passions or hobbies do you have outside of neurology?
Well, since I'm not really inside neurology anymore after 11 years of retirement, um, my passions are now travel, not not exclusively professional, but for leisure, especially cruises. Sports, nowadays more passive, observing
Mm.
than active. The joints age faster than the brain, I believe. Modern arts. I love to go to art exhibitions. I was at the Art Basel Miami last year, and so this is great. And then many people know that, and I even gave a dinner talk at the Society Heavy Metal and Hard Rock, which keep me young and
Yeah.
let me feel alive.
And if someone should look at this, because I feel like there's a disproportionate number of neurointensivists that like heavy metal.
Yeah, I believe that. Yeah. Stroke
I'm not sure what the
neurologists
Venn
in general.
diagram is there, but it's interesting. Yeah.
Yeah, one of my coworkers who is now the head of a big department in northern Germany, he goes every year to the Wacken heavy metal festival in northern Germany. 100,000 heavy metal fans,
Wow.
and he sends his WhatsApps and that. Now I've seen them. Now I've seen them, and I
Mhm.
send back. I've just been to Metallica.
Yeah. Do you have a favorite band?
Yeah, Metallica,
Yeah,
Maiden, and yeah, these are my favorites.
yeah, classics. All right.
Yeah, yeah.
And at the end, we just ask a couple of quick questions for you to complete.
Sure.
Your purpose is or has been.
Now my purpose is staying healthy as far as it's possible, and to enjoy life and my family. And I'm a family person, and I must say my whole career without my safe harbor at home. I never worked at home except for the times when I wrote the textbooks. But
Mhm.
otherwise, from Saturday noon till Sunday late evening, nothing, no work, and family time.
That's great. I recharge by.
Well, the things that I just mentioned before, this
Yeah.
is where I get my energy from, and the family.
I love.
I love good food, great wines. Yeah, and that's about it in my age.
I want to be remembered for.
Yeah, that's a good question. What I would like people to think about me is that you can be relatively successful as a scientist, as a clinician, as a leader, without becoming an unfriendly person. Don't want to use the word that everyone thinks about. And I always try to have an atmosphere in my department, in my group, that everybody would feel well and accepted. And if they remember me for that, that would be great.
Right. And what advice would you give the neurocritical care fellow or trainee that's about to graduate?
Don't be disappointed by setbacks. Go your way. This is a wonderful subdiscipline, and I always see it together with cerebrovascular. I think cerebrovascular and neurocritical care go very well hand in hand, and with that, you can even build a career.
All right. Well, we'll let that be the final word. Dr. Hacke, this has been an absolute pleasure. I really enjoyed talking to you.
It was my pleasure. I hope I was not too long.
No, that was perfect. This has been the Neurocritical Care Society podcast. We are available everywhere you get your podcasts, including the Neurocritical Care Society webpage. Continuing education credits are available for select episodes. Please make sure to subscribe so you don't miss a single episode, and we'll see you next time on the podcast. Take care.